Welcome, curious minds, to another deep dive. Have you ever paused to consider what truly unfolds the very moment you drift off to sleep for surgery? It's a profound transition, really. A moment of deep trust as you hand over consciousness to skilled medical hands. Today, we're going to peel back the layers on that critical first step, the induction of anesthesia. We're about to embark on an extensive deep dive into the intricate world of intravenous, or IV, induction agents. We'll be dissecting a wealth of information from comprehensive sources, really going deep on every concept. Our mission for you today is to equip you with an understanding of these drugs, not just at a surface level, but with the depth and insight of the elite professionals in the field. We'll break down their chemistry, unravel exactly how they work within your body, examine their impact on various systems, and understand the precise reasons why and when each one is chosen.
Yeah, and it's fascinating to consider the history here. Anesthesia has been around a while, but a significant, relatively recent milestone was only reached in 2011. That's when sodium pentothal was discontinued in many countries.
Right, that old thiobarbiturate, introduced way back in the 1930s.
Exactly. It undeniably revolutionized anesthesia delivery back then. But while its use has dramatically declined, the fundamental practice, using IV push boluses to initiate anesthesia, that remains the enduring standard.
So we're looking at what replaced it.
Precisely. We'll explore these sophisticated modern agents that have since taken its place and delve into the powerful science behind why they are so incredibly effective at creating that swift, controlled state of unconsciousness.
So what does this mean for you, our dedicated listener? Well, it's your shortcut to becoming truly well-informed about the very drugs that render patients unconscious, providing, ideally, a pleasant, rapid onset of surgical anesthesia. You'll discover the ideal properties clinicians look for in these agents.
And why a single perfect drug remains elusive, yeah.
Right, but also how the current array of options allows for astonishing precision and tailoring to individual patient needs.
Propofol is kind of the workhorse now, the current standard.
But we'll also unpack the valuable and unique roles of others, Etomidate, Ketamine,
And even Dexmedetomidine. Each seems indispensable for very specific clinical situations.
Absolutely, they all have their niche.
Let's truly unpack this then, okay? Our journey into these powerful agents begins with Propofol. It's often affectionately, or perhaps infamously dubbed, milk of amnesia.
Ha, yeah, that name sticks. Partly the milky white appearance, partly the profound hypnotic effects.
It is, without a doubt, the current gold standard for inducing general anesthesia and providing intravenous sedation across a vast array of clinical settings.
And to really understand it, you have to look at its chemistry. Its structure as a 2.6-disopropylphenol is central to how it behaves. Typically, it's prepared as a 1% solution, but it's not just dissolved in water. It's in a lipid emulsion.
Like a tiny oil and water mixture.
Exactly. Specifically containing 10% soybean oil, 2.25% glycerol, and 1.2% purified egg lecithin. Now, this unique vehicle, while incredibly effective for drug delivery, isn't without its intricacies.
Like the pH difference you mentioned. Right. The trade product Diproven has a pH range of 7 to 8.5, so slightly alkaline, but generic forms can vary, often more acidic, maybe 4.5 to 6.4.
But they share the same pK, around 11.
Yeah, which tells us a bit about how it interacts with the body's pH.
Okay, here's where the practical implications become really critical, though. That lipid emulsion. It's basically a nutrient broth, isn't it?
Unfortunately, yes. It's quite favorable for bacterial contamination if it's not handled meticulously.
Which is why they added preservatives.
Precisely. The original Diproven formulation included 0.005% disodium edetate, EDTA, specifically to inhibit bacterial and fungal growth.
And the generics use other things.
Often 0.025% sodium metabisulfite or benzyl alcohol, depends on the manufacturer. This is a direct response to past infection clusters that happened because of mishandling earlier preservative-free versions.
So sterile technique is non-negotiable.
Absolutely crucial. And it's why any leftover drug must be discarded within 6 hours of being drawn up.
And never use the same syringe or vial for more than one patient.
Never. In fact, there's ongoing research looking at newer formulations, albumin emulsions, micelles, nanoemulsion cyclodextrins.
All trying to get around these lipid emulsion issues.
Exactly, trying to improve stability and reduce that contamination risk.
So while Propofol offers these remarkable advantages, what are some of the inherent challenges clinicians have to navigate?
Well, it's true that Propofol provides that wonderfully rapid onset and offset. Great for minor procedures like colonoscopies, right? Quick in, quick out.
Yeah, patients appreciate that.
But it has a narrow therapeutic index.
Meaning the safety margin isn't huge.
Right. The window between an effective dose and a dose causing significant side effects is quite small. Even slight dose adjustments can easily tip someone into full general anesthesia when you only wanted sedation.
And the blood pressure and breathing effects.
Hemodynamic and respiratory depression, yeah. That can be troublesome, particularly in patients who are already medically fragile.
We've also seen supply issues sometimes, haven't we?
We have. Manufacturing that specific lipid emulsion isn't trivial,
Plus, things like pain on injection.
which we'll talk more about.
And that serious ICU issue, Propofol Infusion Syndrome, PIIS.
A major concern with long-term use. And unlike some other drugs, there's no reversal agent, no pharmacological antagonist.
No antidote.
Nope. Which just underscores the need for really careful, precise management.
Now let's explore the how it works in your body, its pharmacokinetics. This seems to be one of its big selling points.
Definitely a main clinical benefit. After an IV bolus, it rapidly distributes into the brain and other highly perfused areas, tissues getting lots of blood flow.
And that rapid distribution is the key to the fast onset.
Exactly. Usually within a single circulation time, the time it takes blood to get from the arm vein to your brain. Quick entry, immediate hypnotic power.
What's particularly fascinating, though, is the rapid redistribution that leads to waking up so quickly.
Right. Think of the drug molecules circulating. They hit the brain fast, but then they quickly diffuse out of the brain and into other tissues, like muscle and fat, where they get stored temporarily.
So the brain concentration drops fast.
Precisely. And that's why you reawaken rapidly, typically 5 to 15 minutes, but obviously dose and patient dependent.
And liver metabolism isn't the main driver for waking up.
Surprisingly, no. Metabolism by liver enzymes like CYP2B6 and others is vital for eventually clearing the drug from the body, but it plays a minimal role in that initial rapid awakening. In fact, Propofol's metabolic clearance is so fast, it actually exceeds typical liver blood flow.
Which suggests metabolism elsewhere, too.
Correct. Extrahepatic sites of metabolism. That helps explain why its elimination isn't drastically altered even in severe cirrhosis, where the liver isn't working well.
And age definitely matters for dosing.
Absolutely. Elderly patients generally need lower doses, altered kinetics, body composition changes, organ function.
While children need more.
Per body weight, yes. They have a higher volume of distribution, faster clearance per kilo, so they actually require higher doses per body weight to get the same effect.
And accumulation can happen with long infusions because it's so fat-soluble.
Exactly. It's extremely lipid-soluble, readily dissolves in fat. So with prolonged infusions, it can build up in fatty tissues, leading to saturation.
The elimination half-life is typically 1 to 2 hours.
Around there, yeah.
This also brings up that idea of context-sensitive half-time.
Ah, yes. Crucial for drugs given by long infusion, like Propofol often is in the ICU. The standard elimination half-life doesn't really capture the full picture after a long infusion.
So context-sensitive half-time is more clinically relevant.
Much more. It describes the time for the plasma concentration to drop by 50% after stopping a prolonged infusion, factoring in how long it ran. Gives a better sense of recovery time.
Okay, and it binds to blood components.
Right. Reversibly to red blood cells, about 50%, and plasma proteins, mainly albumin, around 48%.
So only a tiny fraction is free and active.
Less than 2%.
Yep.
But if a patient has low plasma protein levels, say, from severe kidney or liver disease or late pregnancy, that can reduce the binding.
Increasing the free active drug.
Potentially, yes. Amplifying effects, especially with prolonged infusions.
And being so lipid-soluble means it crosses barriers easily.
Very easily. Blood-brain barrier, placental barrier, which explains the fast onset and also the effects on a fetus if used in pregnancy.
All right, let's really unpack its mechanism of action. How does it actually cause unconsciousness?
Like many other sedatives, it seems to work by interacting with the body's major inhibitory neurotransmitter, GABA, gamma-aminobutyric acid.
Acting on the GABA receptor complex.
Primarily, yes. These receptors are located throughout the central nervous system.
So remind us how GABA works and how Propofol fits in.
Sure. GABA is the main inhibitory neurotransmitter, the brain's primary brake. The GABA receptor is basically a gate on the neuron, a ligand-gated ion channel. When GABA binds, it opens chloride channels. Negatively charged chloride ions flow into the neuron.
Making it harder for the neuron to fire.
Exactly. It hyperpolarizes the membrane, makes it more negative, inhibiting excitation. Now, what Propofol does is clever. It both directly stimulates these GABA receptors, and it potentiates or enhances the actions of your body's own GABA.
So it kind of boosts the natural calming system.
It supercharges it effectively. leading to that profound CNS depression, the lights out effect we see.
Now let's break down the specific effects propofol has on different body systems, starting with the central nervous system. Patients experience that rapid, usually pleasant loss of consciousness, and hopefully a smooth emergence too.
That's the goal. And for conscious sedation, low-dose infusions provide dose-dependent anxiety reduction, sedation, and amnesia. You often don't remember the procedure.
Connecting this to brain function itself.
Propofol causes dose-dependent reductions in cerebral blood flow, CBF, and the cerebral metabolic rate of oxygen consumption, CMRO2. It also significantly decreases intracranial pressure, ICP, and helps maintain cerebral perfusion pressure, CPP.
Which are generally good things, especially in neurosurgery.
Very beneficial. These effects come partly from lower blood pressure, the depressed brain metabolic rate, and some cerebral vasoconstriction narrowing of brain blood vessels, similar to barbiturates and etomidate in that respect.
But key brain regulation stays intact.
Crucially, yes. Cerebral autoregulation, the brain maintaining its own blood flow despite blood pressure changes and its reactivity to CO2 changes are preserved. That's a big advantage.
Okay. And brainwave activity on EEG.
You see a distinct delta rhythm, like deep sleep, no seizure-like activity. At higher doses, you can get burst suppression where brain activity cycles on and off.
It's even been used for status epilepticus?
It has, successfully, though its use in patients with epilepsy is still a bit debated. Some studies show no issues, but there were isolated reports of increased epileptiform activity in a few epileptic patients. But generally, compared to older agents like thiopental, propofol seems less likely to activate seizure activity.
What about those involuntary movements, myoclonia?
Ah, yes, the spontaneous excitatory movements. Thought to result from selective disinhibition of subcortical centers, some movement control areas become less active.
Can adequate dosing prevent it?
It may help, and the incidence seems lower than with etomidate, which we'll discuss later.
And it lowers eye pressure.
Consistently decreases intraocular pressure, yes. Beneficial for eye surgery.
The idea of it being neuroprotective is still up in the air, though.
Very controversial. Study results are inconsistent in animals and humans. You can't really indicate it solely as a neuroprotectant, but it might play a role in a multimodal strategy by preserving brain perfusion, helping temperature control, preventing infections, indirectly helping neurological outcomes.
And for ECT, electroconvulsive therapy, it was controversial because it shortened seizures.
Initially, yes. Historically, longer seizures were thought to mean better therapy for depression. But we now know that reduction in seizure duration with propofol doesn't seem to compromise the antidepressant effect.
So it's used commonly now.
Very commonly, mainly because of that rapid, clean recovery profile. Big plus for patients.
Shifting to cardiovascular effects. Usually a mild transient drop in blood pressure.
In healthy adults and kids, yes. Typically not clinically significant, resolves quickly.
But it can cause bigger drops in certain patients.
Definitely. Significant hypotension can happen with usual doses, especially in patients over 50, those with severe systemic disease, ASA 3-4, baseline low blood pressure, or getting high-dose fentanyl alongside it.
That drop usually happens quickly, within 10 minutes.
Typically. And it's mainly due to decreased sympathetic tone, less fight-or-flight drive, and widespread vasodilation, blood vessels relaxing. Less about direct heart depression.
So for elderly or cardiac patients, need to be cautious. Lower doses.
Lower doses, or consider alternative agents. Though propofol is used successfully in cardiac anesthesia, often combined with fentanyl in specific low-dose or infusion regimens.
Respiratory effects are also a key consideration. Slowed, shallower breathing is common.
Transient respiratory depression, yes, often more prominent than with etomidate. You usually see bigger drops in tidal volume, the amount of air per breath, than in the rate.
And a brief pause in breathing, apnea, is common right after the dose.
Very common immediately after induction doses. It's dose-dependent, resulting from the respiratory center becoming less sensitive to CO2.
Interestingly, though, minimal effect on airways themselves, but no histamine release.
Correct. Minimal direct bronchodilation, but crucially, no histamine release. That makes it safe and often preferred for asthmatics.
So after intubation, airways tend to be calmer with propofol compared to etomidate.
Generally lower respiratory resistance and less wheezing compared to etomidate. Yeah, makes it top choice, along with ketamine, for patients with asthma or reactive airways.
Beyond the main anesthetic actions, are there other benefits?
Yes, it has mild antiemetic properties, helps prevent nausea and vomiting. Most noticeable with continuous infusions, though the exact mechanism isn't fully clear.
And it helps with itching.
It does exhibit antipruritic effects,
Yeah.
particularly good against opioid-induced itching, a common side effect of painkillers.
Okay, back to that pain on injection. Affects a lot of people.
About 60%, often described as burning, frequently related to using smaller veins, irritating the vessel wall.
But there are ways to reduce it.
Fortunately, yes. The two most effective are simple. Use a larger vein, like in the elbow crease.
The antecubital vein.
Right. Or pre-treat with lidocaine, 20-40 milligram, maybe with grief venous occlusion if injecting into a hand vein.
Mixing lidocaine in the syringe also works.
Yeah.
Or pre-treatment with opioids or other drugs.
Also effective options, yes. Pre-treatment with opioids, ketamine, or NSAIDs can help.
And importantly, if it accidentally goes into an artery.
Reassuringly, it doesn't cause vascular injury, unlike some other drugs.
Now, for obstetric use, high lipid solubility means it crosses the placenta easily.
It does, reaching the fetus when given to the mother.
So, what are the implications for the baby?
Well, when used for C-sections, sedative effects can occur in the newborn, sometimes slightly lower APGAR scores right after birth.
But the anti-nausea effect is a plus for the mother.
Can be an advantage, yeah. It's also frequently used for sedation in procedures like postpartum tubal ligations or for assisted reproductive techniques.
Okay. What about absolute reasons not to use it? Contraindications.
Beyond known hypersensitivity to propofol or its components, or maybe a pre-existing disorder of lipid metabolism, there are actually relatively few absolute contraindications.
But specific warnings are important, especially for some generics.
Very important. Newer generic formulations containing sodium metabosulfite must be avoided in sulfite-sensitive patients,
Because that can trigger severe reactions.
including anaphylaxis or asthma attacks, especially in patients who already have asthma, where sulfite sensitivity is more common.
And general caution always advised in elderly, debilitated, or cardiac patients.
Always, due to that potential for hemodynamic and respiratory depression.
Also, a specific caution for kids with cardiac mitochondrial disease.
Yes, avoid large bolus doses or continuous infusions in those patients. Propofol can interfere with mitochondrial energy production, which can be detrimental in those specific cases.
This brings us to that tricky, nuanced point. Propofol and allergies, specifically egg, soy, peanut.
Ah, yes, the lecithin controversy. The lipid emulsion contains lecithin, originally from egg yolks, though now also from soy and other sources. Historically, this caused concern about using it in allergic patients.
But the clinical picture is complex, with different warnings in different countries.
Exactly. Diprivan might have an egg soy warning in Australia, a soy peanut warning in the UK, but no food allergy warnings in the US for essentially the same product.
So what's the expert consensus now?
Largely, experts agree there's little scientific evidence to avoid propofol in patients with egg or soy allergies.
Why is that?
Well, lecithin comes from egg yolks. Egg allergy is typically to egg whites, so the connection isn't supported immunologically. And the refined soy oil used in propofol has the allergenic proteins removed during processing, making it generally safe for soy allergic patients.
What about the peanut connection? Shared plant family with soy.
While there's a theoretical cross-reactivity suggestion, there's just no confirmed data showing propofol causes anaphylaxis in peanut allergic patients. The evidence simply isn't there to support avoiding it in these populations.
Okay, let's shift to a very serious, though rare, concern. Propofol Infusion Syndrome, PRIUS.
Yes, a severe, often lethal condition linked to long-term, high-dose propofol infusions, mostly seen in ICUs. Significant morbidity and mortality when it occurs.
The exact mechanism isn't fully proven.
Still unproven, but the proposed pathophysiology is quite detailed. Several risk factors are identified.
Like high doses for long periods.
Doses over 5 millibring hour, infusions longer than 48 hours, critical illness itself, high-fat, low-carb diets, underlying mitochondrial issues, and co-administration of high-dose catecholamines or steroids.
And historically, it affected children significantly.
Yes, many early cases were in children, which led to the strong recommendation against long-term propofol infusions in kids now. Multimodal sedation is preferred, keeping propofol rates as low as possible.
The syndrome seems triggered by propofol when circulation and oxygenation are already compromised.
Exactly. It seems to create a dangerous oxygen supply-demand mismatch at the cellular level. This can lead to tissue death, necrosis in cardiac and peripheral muscle, especially if catecholamines and steroids are also on board.
So what does this all mean for the patient at the cellular level? What's the theory?
The leading theories suggest propofol inhibits oxidative phosphorylation, how cells make energy, possibly by blocking fatty acid transport into mitochondria, directly inhibiting the mitochondrial respiratory chain itself, or blocking beta receptors and cardiac calcium channels.
So it fundamentally disrupts energy production.
All evidence points towards a defect in ATP production as the likely cause, with the mitochondria being central.
And the clinical signs are devastating.
Severe metabolic acidosis, heart failure that doesn't respond to treatment, persistent slow heart rate, fever, severe liver, and kidney problems. You can also see EKG changes, dangerous heart rhythms, muscle breakdown, high potassium, high blood fats, enlarged liver. It's a cascade.
A 2015 analysis of case reports showed some trends.
It did. Early priest deaths in the 90s were often kids with respiratory infections on high doses. Today, it's more often adults or elderly patients in the ICU. The presentation might be subtler initially, maybe just mild unexplained acidosis, and a very high CK level, over 5,000 UL being high risk.
But other classic features might be missing in adults.
Often, yes, making diagnosis challenging.
What predicted death in that analysis?
Cumulative propofol dose, rate and duration, pre-existing traumatic brain injury, and fever were independent predictors.
Treatment is basically supportive. Stop the propofol immediately.
Absolutely. Stop the drug, aggressively support breathing and circulation, cardiac pacing if needed, drugs like phosphodiesterase inhibitors or glucagon, potentially ECMO for life support, and dialysis for kidney failure.
And the recommended limits to try and prevent it.
No more than 48 hours of infusion and keep the rate below 4 millicurie hour, which is about 67 millicurie hour. Moving on from propofol, let's explore Etomidate. This one seems reserved for specific situations where propofol might be too risky because of its cardiorespiratory effects. Exactly. It holds a unique niche. Its primary clinical advantage is truly minimal cardiorespiratory depression.
Making it great for unstable patients.
Excellent alternative for hemodynamically unstable patients, those in shock or maybe with compensated heart disease. It offers a stable induction, maintaining heart rate, blood pressure, cardiac output.
But it comes with a catch, you said, or several catches.
It does have significant side effects that limit its wider use. Pain on injection is common. Myoclonia, those involuntary muscle movements, can be quite pronounced.
Nausea, vomiting.
Yes, and most notably, adrenocortical suppression. It temporarily dampens adrenal gland function.
And no pain relief either.
Correct. Lacks intrinsic analgesic properties entirely.
So what exactly is Etomidate chemically?
It's a carboxylated imidazole derivative, synthesized back in '65, used in Europe since '72. It has two isomers, but only the plus isomer has the hypnotic effect. The current formulation is 2 mg/ml and 35% propylene glycol. That gives it a pH of 8.1, slightly alkaline, and a pK of 4.2.
And research is ongoing to reformulate it, trying to keep the good stuff but lose the adrenal issue.
Precisely. Trying to maintain that cardiovascular stability while reducing or eliminating the inhibition of adrenal steroid production.
Let's look at its pharmacokinetics. How does the body handle it?
It's rapidly metabolized, both in the liver by microsomal enzymes and by plasma esterases in the blood, primarily through ester hydrolysis, breaking it down into inactive carboxylic acid metabolites.
And elimination.
About 10% recovered in bile, 13% in feces, the rest eliminated by the kidneys.
Its short duration is mostly due to redistribution, like propofol.
Largely, yes. Rapid redistribution from the brain to other tissues allows patients to wake up quickly, usually 5 to 15 minutes after a bolus.
High lipid solubility lets it get into the brain fast.
Right, and it has a huge volume of distribution, spreading widely. Total body clearance is rapid.
And importantly, it doesn't accumulate with repeated doses.
Lack of accumulation is a significant advantage. Its terminal half-life, the final elimination phase, is 2 to 5 hours.
Protein binding.
About 76% bound, mostly to albumin. While theoretically low protein could increase the free drug, clinical impact is rare because metabolism and elimination usually compensate.
Its mechanism also involves GABA modulation.
Yes, similar to many CNS depressants.
But a key safety point confirmed early on, no histamine release.
Correct. A large clinical investigation confirmed it does not cause histamine release, unlike some older agents. Big plus for patients with reactive airways.
Okay, let's unpack its pharmacodynamics, starting with the CNS.
It produces dose-dependent CNS depression, unconsciousness usually within 1 arm brain circulation time. Duration depends on the dose, awakening in 5 to 15 minutes, typically after 0.2-0.4 millikilograms.
But zero pain relief.
Absolutely none. Needs to be paired with analgesics.
It significantly decreases brain blood flow and metabolic rate.
Yes, CBF down by about 34%, CMARO2 down by 45% in studies, while maintaining the brain vessel's response to CO2. It also decreases intracranial pressure while maintaining cerebral perfusion pressure.
Which makes it valuable in neurosurgery, especially with that cardiovascular stability.
Exactly. I mean, arterial pressure usually stays high enough for cerebral autoregulation to work. EEG changes are similar to other IV agents, though uniquely lacks beta wave activity during induction compared to thipental.
Now, that myoclonia, it affects a lot of patients.
Incidence varies, 10% to maybe 60%. Sudden, generalized, asynchronous muscle contractions can look like seizures.
But they aren't actual seizures on EEG.
Correct. EEG monitoring confirms no specific epileptiform activity.
Yeah.
It's thought to be related to uneven drug distribution causing disinhibition, not direct stimulation.
Can pre-medication help reduce it?
Yes, pre-treatment with small doses of dexmedetomidine, midazolam, rocuronium, or lidocaine is effective.
It also decreases eye pressure.
Yes, consistently lowers IOP. Affects other monitoring like BIS similarly to propofol. Auditory evoked potentials are affected differently.
And interestingly, it prolongs seizure activity after ECT compared to propofol.
It does. Somatosensory potentials are enhanced, motor potentials suppressed less than with propofol.
Okay, cardiovascular effects. This is its main selling point.
It's calling card, definitely. Remarkable hemodynamic stability upon induction, even in healthy or moderately sick patients. In those with compensated heart disease or high-risk factors, it generally maintains heart rate, pulmonary artery pressure, cardiac index, SVR, and systemic blood pressure.
Any slight drop in BP is due to
reduced systemic vascular resistance, usually, not direct heart depression.
And this stability comes from its unique lack of sympathetic depression.
Lack of depression of the sympathetic nervous system and preserved baroreceptor function. Plus, it acts as an agonist at alpha-2b adrenoceptors, further helping maintain blood pressure. Myocardial oxygen supply and demand stay balanced. No significant arrhythmias. Renal and hepatic blood flow maintained.
So compared to propofol?
Propofol causes the most cardiorespiratory depression, Etomidate the least. That's the trade-off.
Regarding respiratory effects, it does cause some dose-dependent depression.
Yes. Typically decreases minute volume while increasing respiratory rate. But the depression is significantly less than with propofol.
It decreases the response to CO2, can cause brief apnea.
Yes, though apnea is generally less frequent and shorter than with other agents.
But crucially, little effect on bronchial tone and no histamine release.
Correct. Makes it a much safer option for patients with reactive airway disease compared to drugs that might trigger bronchoconstriction.
Now, the big one. The most studied and limiting side effect, adrenocortical suppression.
Yes, this caused major concern after about 10 years of use in Europe. Increased mortality was seen in critically ill patients getting Etomidate infusions linked directly to adrenal hypofunction, low cortisol.
And studies show even a single dose can suppress adrenal hormones for hours.
For 8 to 24 hours after a single induction dose, potentially over 24 hours with an infusion.
How does it do that?
It's a reversible, dose-dependent inhibition of adrenal steroid production. Specifically, it blocks the mitochondrial enzyme 11-beta-hydroxylase, which is essential for making cortisol and aldosterone. It hits a few other enzymes too, leading to a buildup of precursors but decreased active hormones.
This raises huge questions, especially for patients with sepsis.
The controversy over increased morbidity and mortality from this adrenal suppression in septic patients needing intubation is ongoing and complex. While giving steroids can help reverse septic shock faster, showing a clear benefit in overall mortality after Etomidate induction hasn't been consistently proven in all studies.
And the suppression can last a long time in critically ill patients.
Over 24 hours, sometimes up to 72 hours, even after just one dose.
So what's the recommendation? Consider steroids. Avoid Etomidate in sepsis.
It's debated. Some suggest empirical steroid supplementation for 48 hours in critical patients if Etomidate was used, even without overt shock. But many professional bodies suggest considering alternative induction agents for septic patients, especially those already on vasopressors or with abdominal infections, given this potential risk. More research is definitely needed.
Beyond adrenal suppression and myoclonia, what other side effects? Pain, nausea.
The propylene glycol formulation is notorious for causing burning pain on injection up to 90% of patients, and thorbol phlebitis, vein inflammation, in up to 50% later on.
Can lidocaine help with the injection pain?
Yes. Like with propofol, pre-treating with lidocaine and using larger veins helps significantly. Reassuringly, accidental artery injection doesn't cause vascular injury.
Nausea and vomiting are common too?
30–40% incidence. Co-administering opioids can make it worse.
Finally, contraindications. Known sensitivity, adrenal suppression, and acute porphyrias.
Right. Strictly avoid in patients with known sensitivity, existing adrenal issues, and acute porphyrias.
Why specifically porphyrias?
These are rare inherited metabolic disorders affecting heme synthesis. Acute types are dangerous because certain drugs, including etomidate and barbiturates, can trigger a severe attack.
How?
They induce an enzyme called ALA synthetase, the rate-limiting step in heme production, setting off the cascade. Symptoms can be severe, intense pain, psychological issues, seizures, cardiovascular problems.
So for porphyria patients, etomidate is out. What are the safe options?
Propofol and ketamine are the induction agents of choice. Most muscle relaxants and all current inhaled agents are considered safe too. Opiates and local anesthetics for pain are also generally fine.
Next up, let's explore ketamine. This one has a really fascinating history and a unique place in anesthesia today, doesn't it? Especially for specific patient groups.
Absolutely. Its unique advantages make it incredibly useful. Think high-risk patients, kids, people with asthma, and it offers excellent pain relief, really useful for perioperative pain.
Introduced in 1970, and it produces that dissociative anesthesia state.
Right. Going by Corson and Domino. It's not typical sleep. The patient feels separated, dissociated from their environment. But crucially, they have profound analgesia and amnesia, yet most protective reflexes remain intact. It doesn't follow the usual signs and stages of anesthesia.
Chemically, it's a cyclohexanone derivative.
2-achlorophenol-2-methylamino-cyclohexanone. pK of 7.5, slightly acidic pH, 3.55.5. In the U.S., it's a racemic mixture, both R and S plus isomers. The S plus isomer is available elsewhere, but its supposed advantages seem pretty minor in practice.
So how does it create that dissociative state? What's the mechanism?
The primary mechanism is antagonism at NMDA receptors, N-methyl-D-aspartate receptors in the brain. This selectively depresses the medial thalamic nuclei, blocking pain signals from reaching the thalamus and cortex.
NMDA receptors are usually activated by glutamate, the main excitatory neurotransmitter.
Exactly. Glutamate opens ion channels there. Ketamine acts as a non-competitive antagonist, blocking this excitatory action without directly fighting glutamate for the binding site.
What's really fascinating is how that affects brain processing. Impulses get through but aren't interpreted properly.
Right. Signals reach cortical regions but aren't processed normally, leading to inappropriate responses to stimuli. And while some cortical areas are depressed, the limbic system involved in emotion and excitation is simultaneously activated. This unique combo contributes to that dissociative feeling.
It affects other receptors too, opiate, monoamine.
Yes, it interacts with a wide array of receptors. Opiate, monoamine, cholinergic, purinergic, adenosine, contributing to its complex effects. Plus, it inhibits inflammatory mediators like TNF-alpha and IL-6, which might explain some anti-inflammatory and anti-hyperalgesic effects.
And the pain relief involves the spinal cord too.
Significant spinal component, yes. Studies show it blocks pain signal transmission at the dorsal horn by inhibiting certain neuron activity there.
Okay, let's talk pharmacokinetics. How does the body handle ketamine?
Metabolized mainly in the liver by microsomal enzymes, primarily through demethylation to norketamine.
Is norketamine active?
Yes, it retains about 20–30% of ketamine's activity, contributing to the overall effect duration. Then further hydroxylation and conjugation make water-soluble compounds eliminated mostly by the kidneys.
Distribution follows a two-compartment model. Fast into tissues, then slower out.
Exactly. It crosses the blood-brain barrier quickly. But clinical onset for full surgical anesthesia is actually slower than propofol or etomidate, maybe 3 to 5 minutes with a standard dose.
Awakening is due to redistribution, like the others.
Usually 15–30 minutes due to redistribution from central to peripheral tissues. But it can vary widely, especially with high or repeated doses. Elimination half-life is 2 to 3 hours.
And its elimination depends on liver blood flow.
Hepatic extraction is high, so yes, dependent on liver blood flow. It's only about 12% protein bound, so more free drug circulating compared to others.
What's really cool here is its versatility. You can give it IM.
Intramuscularly, yes. 46 millijoule kilograms. Peak plasma levels in about 20 minutes. Onset, 5–15 minutes. Bioavailability is high, about 93%.
And even lower IM doses work for pain relief without knocking someone out.
Right. Around 0.44 millijoule kilogram IM can provide analgesia without loss of consciousness or those psychic disturbances.
And orally, too, for uncooperative kids.
Even orally, 10 millijoule kilograms, often mixed in syrup. Onset 10–20 minutes. A really valuable option sometimes.
Diving into pharmacodynamics, the CNS effects are truly unique, that dissociative state.
Where the patient seems disconnected, the slower onset can make judging sleep and analgesia a bit tricky sometimes.
And they look cataleptic, eyes open, pupils reactive.
Often, yes. Eyes open, reactive pupils, corneal reflexes intact, maybe nystagmus, tearing, blinking, increased salivation.
Airway reflexes usually stay intact. Laryngeal, pharyngeal, cough.
Generally remain intact, but crucially, some reduction can occur. Rare cases of silent pulmonary aspiration have been reported, so you still need vigilance.
Skeletal muscle tone increases, occasional purposeless movements.
Yes. And because those traditional signs of anesthesia aren't there, movement in response to pain often becomes the main guide for dosing adequacy.
Reorientation takes 15-30 minutes, but variable.
Wide variability depending on dose and patient.
It provides good analgesia, especially for skin, bone, joint pain, even at low doses.
Moderate to strong analgesia, yes. Makes it popular for sedation combined with low-dose benzos or propofol in a multimodal approach.
Now, the effects on cerebral dynamics are different. It increases CBF and ICP.
Paradoxically, yes. Increases cerebral blood flow, regional and maybe global metabolic rate, and intracranial pressure. Glucose use varies by region. Cerebral vessels still respond to CO2, though.
Historically, this meant it was contraindicated in head injuries or high ICP.
Traditionally, yes.
But that's changed somewhat.
This raises an important point about evolving practice. It's now recognized that ketamine can be used safely in neurologically impaired patients, but under specific controlled conditions.
Like controlled ventilation, co-administering a GABA agonist like midazolam or propofol.
Exactly, and avoiding nitrous oxide. Trauma patients in particular can benefit from its good cardiovascular effects while minimizing neurological issues if managed carefully.
EEG patterns are atypical too. Alpha to theta on loss of consciousness.
Yes, and alpha only reappears after consciousness returns. It doesn't reliably decrease BIS, can even increase it when added to other agents, doesn't alter AEPs, advantageous for ECT.
Okay, here's where it gets really interesting for patients. Emergence reactions, the psychic disturbances.
Yes. Immediately on waking, patients can experience vivid illusions, feeling drunk, delirium, restlessness, altered states, out-of-body sensations, even combativeness.
Affects about 12%. Influenced by age, dose, gender.
Right. Psychological predisposition. Concurrent meds also play a role. Some even report recurrent dreams weeks later. Usually starts with first verbal contact on waking. Resolves in hours.
So how do you manage these? Benzodiazepines help?
Benzodiazepines, diazepam, lorazepam, midazolam significantly decrease the incidence and severity when given beforehand or alongside.
And with lower doses for pain, reactions are less common, but maybe still vivid dreams.
Less frequent, yes, but vivid dreaming can still occur. Positive suggestions during recovery might help reduce recall of unpleasant dreams.
Little effect on nausea vomiting, but can reduce opioid needs.
Correct on both counts. Reducing opioid requirements is a big plus.
Moving to cardiovascular effects. Ketamine is a stimulant, unlike the others.
Powerful circulatory stimulant. Increases systemic blood pressure, heart rate, cardiac contractility and output, central venous pressure. SVR response varies. Can increase pulmonary vascular resistance initially.
This increases the heart's oxygen demand.
It does, due to increased contractility, but usually this is balanced by a simultaneous rise in coronary artery perfusion, so the heart muscle gets enough oxygen in healthy individuals.
What's the mechanism behind this stimulation, sympathetic nervous system activation?
Primarily, yes. Ketamine triggers the sympathetic system, releasing endogenous catecholamines like adrenaline. It also seems to inhibit norepinephrine reuptake, further boosting positive inotropic effects, stronger heart contractions.
But in vitro, it has negative effects.
In a test tube, yes, by decreasing intracellular calcium. But in patients with an intact sympathetic system, the positive indirect effects overwhelmingly dominate.
Except maybe in critically ill patients with depleted catecholamines.
They might experience the negative effects more prominently, as their body can't mount that strong sympathetic response. Some inhaled anesthetics can also block ketamine's CV effects, and benzos can be used deliberately to blunt the stimulation if needed.
This makes ketamine incredibly useful for unstable patients. Shock, trauma, hypovolemia.
Hugely useful. Often the agent of choice to maintain cardiovascular stability in those critical situations. Blood pressure changes are dose-related. Heart rate response tends to plateau. Used successfully in complex pediatric and adult cardiac surgery, too.
Respiratory effects are generally minor. Ventilation preserved.
Usually minor and short-lived. Ventilation and normal breathing preserved. Transient apnea is rare, usually only with rapid injection of large doses. Blood gases stay normal. Response to CO2 maintained.
Now, here's where it gets really interesting for asthmatics. It's a bronchodilator.
Remarkably, yes. It increases pulmonary compliance, makes lungs stretchier, and decreases pulmonary resistance in patients with bronchospastic disease. It is the only active bronchodilating induction agent among those we're discussing.
Making it the agent of choice for active asthma.
Absolutely. Helps keep airways open, prevents bronchospasm. The bronchodilation is likely due to increased catecholamines, direct smooth muscle relaxation, and blocking vagal constriction.
A drawback, though, increased secretions. Saliva, bronchial secretion?
Yes, often requires an antisialagogue like atropine. Glycopyrrolate isn't usually as effective for this.
But muscle tone of tongue and jaw is retained, preserving airway reflexes.
Generally preserves protective pharyngeal and laryngeal reflexes, though, again, some reduction is possible, and silent aspiration has been reported rarely.
What about effects on the eye, intraocular pressure? Results are mixed.
Varied results in studies. Depends on measurement technique, other drugs used. Generally, ketamine tends to increase IOP, but it seems dose-dependent. Higher doses might raise it, lower doses might not.
Nystagmus, increased muscle tone around the eye, makes it less ideal for some eye surgeries.
Can make it less suitable where absolute immobility is needed. However, for procedural sedation in the ER at lower doses, equals 4 mg/kg, it doesn't seem to cause clinically significant IOP increases. And it has a unique benefit in blocking the oculocardiac reflex during strabismus surgery, even better than propofol, another niche advantage.
Finally, obstetric and pediatric use. Highly lipid-soluble, crosses the placenta readily.
It does.
But the dose matters hugely for the baby.
Critically, as an induction agent for the mother, 0.5 to 1 mg/kg, it provides rapid anesthesia without harming uterine tone, blood flow, or the baby's status. For analgesia during labor, 0.25 mg/kg, good pain relief, stable airway, sustained maternal BP allows contractions.
But higher surgical doses, 2.5 mg/kg, can depress the neonate.
Yes. Hence the recommendation for lower doses, 1.21 mg/kg, to minimize CNS depression in the newborn, relying on rapid maternal redistribution and less fetal transfer.
It's very versatile in kids, though. Sedation, analgesia, stability.
Especially useful for sedation, pain relief, amnesia, maintaining cardiac respiratory stability. Great for uncooperative kids, those with difficult airways or asthma. Amoral routes are huge pluses.
This brings up that neurotoxicity concern again. Still controversial for ketamine.
Ongoing controversy, yes. Neuroapoptosis seen in animal models when used in the developing brain. Whether this translates directly to humans is unclear.
An intense area of research like the Smart Tots Initiative is investigating.
Exactly. Trying to figure out the real risk, if any, in human infants and children.
Let's transition now to benzodiazepines. These seem widely used, maybe more as adjuncts than primary induction agents.
That's generally true. They're used across numerous situations because they offer a desirable range of properties. Things like sedation, hypnosis, muscle relaxation, anxiety reduction, anxiolysis, anticonvulsant effects, and amnesia, and usually with a low incidence of serious side effects.
The first one was chloridized epoxide, way back in 1955.
Right. Then midazolam came along in 1976, specifically designed with anesthesia in mind.
It has that unique structure, making it water-soluble initially.
Exactly. Water-soluble at pH 4.0, so it avoids irritating vehicles like propylene glycol, minimal vein irritation.
Midazolam is used a lot for anxiety, sedation, amnesia, but rarely to induce full anesthesia.
Correct. The high doses needed would cause very prolonged effects. It's great for conscious sedation and pre-medication, though.
Diazepam and lorazepam are available IV too, but maybe for longer sedation needs.
Generally reserved for inpatients needing more prolonged sedation due to their longer action.
Now here's where it gets really interesting. That new ultra-short-acting one, remimazolam.
Yes, currently in development and showing great promise for procedural sedation, induction, and maintenance of anesthesia.
What makes it unique? Organ-independent metabolism.
Exactly. Like remifentanil, it's rapidly broken down by non-specific tissue esterases found all over the body into inactive metabolites.
So a cleaner, faster, more predictable profile.
That's the goal. Precise control for clinicians.
Chemically, all benzodiazepines share common features. The ring system.
A core benzodiazepine ring. Nitrogens at positions 1 and 4, a phenyl group at 5, an electronegative group at 7.
And midazolam's unique imidazole ring gives it that water solubility trick.
Right. Allows water-soluble salts at acidic pH, avoiding irritating vehicles. Then in the body's physiological pH, above 4.0, the ring closes, it becomes lipophilic.
Fat-loving. And crosses membranes fast for rapid onset.
Precisely. Injectable midazolam has saline, EDTA, benzyl alcohol, pH around 3, Diazepam solution uses propylene glycol, alcohol, benzyl alcohol. Lorazepam uses polyethylene glycol, benzyl alcohol. Formulation matters for injection side effects.
Okay, the fundamental mechanism. How do benzodiazepines work?
Their effects come from acting as agonist activators at specific binding sites on the GABA receptor throughout the CNS.
Back to GABA, the main inhibitory neurotransmitter.
Right. The GABA receptor complex is this 5-part protein machine. It has binding sites for GABA, benzos, barbiturates, ethanol, propofol.
But benzos don't directly open the channel.
No. They bind to their own site and allosterically increase GABA's binding affinity. They subtly change the receptor shape, making it more receptive to GABA.
So they increase the frequency of chloride channel opening.
Exactly. More chloride flows in, hyperpolarizing the neuron, inhibiting transmission. They amplify the natural calming system.
So what does this allosteric mechanism mean for their safety? Why are they generally safer than, say, barbiturates?
Because they work by enhancing endogenous GABA, there's a physiological ceiling. They can only boost GABA's effect. They can't force the system beyond natural limits by themselves. This inherent limit contributes significantly to their favorable safety and low toxicity compared to drugs that might directly open the channel regardless of GABA.
There are different types of ligands for these receptors: agonists, antagonists.
3 classes. Agonists like midazolam, diazepam, lorazepam, which activate the calming effect. Antagonists like flumazenil, which block the site without causing an effect. And inverse agonists, which would cause stimulation not used clinically.
And peripheral benzocytes exist too, outside the CNS.
Yes, in mitochondrial membranes, not linked to GABA. May modulate cardiovascular and immune function, suggesting broader roles.
Let's look at their pharmacokinetics. Newer ones are designed for better profiles.
Yes, chemical tweaks for simpler metabolism, fewer active metabolites, leading to more predictable time courses.
They're classified by half-life. Diazepam long, lorazepam intermediate, midazolam short.
Broadly, yes. Diazepam 24 hours, lorazepam 24 hours, midazolam 6 hours.
But termination of effect is mostly redistribution out of the CNS.
Primarily, yes, like other induction agents. Kinetics are influenced by age, gender, obesity, race, liver-kidney function.
Midazolam clears fastest, hence shorter action.
Higher clearance rate, yes. Lorazepam relies less on liver cytochrome enzymes, uses conjugation more, so liver disease affects it less.
Diazepam's slow distribution limits its use for induction.
Very slow distribution half-life makes it unsuitable for rapid onset offset.
Diazepam is extremely lipid-soluble, spreads widely.
Yes, extensive tissue distribution, large volume of distribution. All 3 are highly protein-bound, mostly to albumin. Diazepam 99%, midazolam 95%, lorazepam 85–90%.
It's fascinating is diazepam's relationship between half-life and age, almost linear increase.
Yeah, striking. In the elderly, pharmacokinetics are really altered. Slower absorption, more fat tissue for storage, less protein binding, slower liver metabolism, reduced cardiac output.
All leading to slower onset but higher, longer-lasting levels in the brain.
Exaggerating and prolonging the drug's effects significantly.
Diazepam also has active metabolites, like noriazepam and oxazepam.
Yes, metabolized by liver enzymes to active metabolites. Noriazepam especially contributes to the prolonged effect because it's metabolized much slower. Oxazepam is also active.
So action terminated first by redistribution, then slow metabolism, terminal half-life 20–50 hours.
Explains his very prolonged sedation.
Now for pharmacodynamics, CNS effects. Dose-dependent depression, anxiety relief to sedation to sleep.
All 3 produce that spectrum, yes. Anxiolysis, sedation, sleep, and at high enough doses, anesthesia.
Plus anticonvulsant effects, amnesia, muscle relaxation, useful for alcohol withdrawal.
All valuable properties. Not antiemetic themselves, but lorazepam is used for anticipatory nausea vomiting in chemo, leveraging its sedative amnestic effects.
At higher doses, they reduce brain metabolism and blood flow.
Yes, reduce CMRO2 and CBF. They also increase the seizure threshold to local anesthetics, making midazolam a common premedicant for regional blocks.
All benzos cause anterograde amnesia, difficulty forming new memories?
Dose-related antegrade amnesia, yes, but generally not reliable retrograde amnesia for memories before the drug.
IV midazolam causes amnesia quickly, lasting 20–30 minutes, affecting short and long-term memory.
Yes, affects various memory types, episodic, semantic, iconic during that window.
EEG shows alpha rhythm disappearing, replaced by beta activity.
Correct. Tolerance, dependence, withdrawal can occur. And midazolam has powerful synergistic effects with fentanyl-enhancing CNS, CV, and respiratory depression. Needs careful monitoring.
Cardiovascular effects are usually minimal at standard doses.
Generally minimal, yes.
But mild BP drop possible, especially with opioids or in elderly cardiac patients?
Occasionally seen in those situations where compensatory mechanisms might be weaker.
Respiratory effects are dose-dependent depression. Midazolam the most potent.
Yes, dose-dependent respiratory depression. Midazolam is considered the most respiratory depressing of the common ones.
What's really key here is the risk when combined with other depressants like opioids.
Hugely important potential for significantly increased respiratory depression and even apnea when combined. Synergistic effect requires extreme caution and monitoring.
Contraindications and precautions. Main risks are unexpected respiratory depression, oversedation.
Those are the most common adverse effects.
Yeah.
Also implicated in postoperative cognitive dysfunction, especially in the elderly. And like Etomidate, avoid in acute porphyrias.
So what does this mean for their primary use? Midazolam is the go-to for pre-medication.
It's the standard for preoperative medication, yes. Rapid onset, short duration half-life, lack of major side effects make it ideal as a preoperative, anxiolytic, sedative, and amnestic. Helps patients relax before surgery, often without remembering the lead-up.
Speaking of benzodiazepines, if you need to reverse their effects quickly, there's Flumazenil.
Right. Flumazenil is the only specific benzodiazepine antagonist available in the U.S. It's a competitive antagonist, binds to the same receptor site with high affinity, but produces no effect itself. It just blocks or displaces the benzoagonist,
Resulting in prompt, effective reversal.
prompt and specific reversal of benzo effects, whether from anesthesia or overdose.
This raises the question, what's the catch? Its duration is relatively short.
That's the main limitation. Its short duration and half-life, around 0.7 to 1.3 hours, mean residation is a real clinical possibility.
Especially in overdose cases where lots of benzo might still be around.
Exactly. The agonist might still be present or redistributing back into the blood. Clinicians need to watch for the patient getting sleepy again after the Flumazenil wears off.
How is it given? Slow 5e titration.
Slow titration is key. Usually 0.2 milligram doses, up to 1 milligram total, until the desired level of consciousness is reached. Rarely need more than 1 milligram for reversing midazolam sedation, maybe up to 3 milligram total for suspected overdose.
Onset is fast, 1-2 minutes. Duration 45-90 minutes.
Yes, depending on the Flumazenil dose and how much agonist needs reversing.
Contraindications are critical here, not for benzo-dependent patients.
Absolutely crucial. Giving it to dependent patients risks severe withdrawal reactions, including seizures.
Also avoid unsuspected tricyclic antidepressant overdose or history of seizures.
Yes, it can lower the seizure threshold in those situations. Very important.
And it won't reverse ethanol or barbiturates.
Correct. Flumazenil only works on the benzodiazepine receptor site. It has no effect on alcohol or barbiturates, which act differently.
Side effects are rare, maybe mild anxiety.
Rare, though mild anxiogenic effects reported. Seizures have occurred in those contraindicated situations, like TCA overdose, reinforcing why adherence to contraindications is vital.
Our final deep dive into a specific agent brings us to Dexmedetomidine. This one's an alpha-2 receptor agonist, offering a unique type of sedation, almost like natural sleep.
That's a good way to put it. The sedative and analgesic effects of alpha-2 agonists like clonidine and even the veterinary drug xylazine have been known for a while. Dexmedetomidine was developed as a more selective alpha-2 agonist refined pharmacology for better sedation with fewer side effects. It's in the imidazoline chemical class.
So what are its primary effects? How does it stand out?
It provides sedation, yes, but also significant analgesia, pain relief, anxiolysis, anxiety reduction. It reduces postoperative shivering and agitation, and has beneficial cardiovascular sympatholytic actions, dampens the sympathetic fight or flight system.
Quite a package.
Makes it very versatile.
If we connect this to the mechanism stimulating alpha-2 adrenoreceptors.
In the CNS and cardiovascular systems, yes. There are 3 subtypes, alpha-2A, 2B, 2C, with different functions. Dexmedetomidine is highly specific for alpha-2 over alpha-1 receptors, 1600.1 ratio. That selectivity is key.
And presynaptic alpha-2 receptors act like brakes on neurotransmitter release.
Exactly. They function as autoreceptors in a negative feedback loop. Stimulating them with dexmedetomidine decreases catecholamine release. The main site for its sedative action is the locus coeruleus in the brainstem, a key area for wakefulness.
Activation of these receptors leads to inhibition.
Leads to a cascade, inhibits calcium channels, activates potassium channels, directly modulates protein release, ultimately hyperpolarizing the cell and inhibiting neuronal activity. That's the sedation mechanism.
Okay, let's unpack its chemistry and pharmaceutics, marketed as Presidex.
Yes. Sterile, non-pyrogenic solution for IV infusion, but only after dilution. Chemically, it's the S enantiomer of imidatomadine, freely water-soluble, pKa of 7.1, The solution is clear, colorless, isotonic, matches blood's osmotic pressure, pH 4.57.0, and crucially, preservative-free, no additives.
Supplied concentrated 100 milligml must be diluted.
Must be diluted. Typically add 2 millirad to 48 milliliters of saline for a final concentration of 4 milligml.
Standard dosing involves a loading dose, then maintenance infusion.
Loading dose, usually 1 millit Ch/kg over 10 minutes slow infusion, is important for safety, followed by maintenance infusions of 0.2 to 0.7 millit/kg.
Approved for up to 24 hours in ICU and for short procedural sedation in non-intubated patients, but used more widely off-label.
Yes, approved for those specific uses, but its unique profile means it's widely used for many off-label applications now.
What about pharmacokinetics, rapid distribution?
Rapid distribution phase, half-life around 6 minutes, terminal elimination half-life about 2 hours, steady state volume of distribution 118 L, clearance 39 hour.
What's fascinating here is its linear kinetics, predictable effects with dose.
Linear kinetics across typical dose ranges up to 24 hours, yes. Makes titration easier. Target concentrations usually 0.3, 0.6 ngml.
Highly protein-bound.
94% bound to albumin and alpha-1 acid glycoprotein. Undergoes almost complete biotransformation, very little unchanged drug excreted.
Metabolism involves glucuronidation and CYP450, no active metabolite.
Correct, both pathways involved. Critically, no active metabolites. Contributes to its clean recovery. Similar kinetics in kids.
Onset 10-20 minutes with loading dose. Duration 10-30 minutes after stopping.
Roughly, yes.
Let's delve into pharmacodynamics, starting with CNS effects. Sedation resembles natural sleep, unlike GABA agonists.
Yes, very distinct. Patients look like they're naturally asleep.
Why is that so significant clinically?
2 huge reasons. Patients do not experience significant respiratory depression, and they remain readily arousable.
You can wake them easily.
Easily awakened to follow commands or for neurochecks. This arousable sedation is a unique advantage, ideal for procedures needing wake-up tests, like spinal surgery, or frequent neuroassessments in ICU.
Doesn't interfere with brain monitoring either, like for awake craniotomies.
Correct. Allows brain mapping or microelectrode recording, doing deep brain stimulator implants, crucial for preserving neurological function.
It decreases BIS values but doesn't change brain metabolism, though blood flow decreases.
Right. Decreases BIS dose dependently. Doesn't change CMRO2 significantly. But CBF is decreased due to vasoconstriction, suggesting an uncoupling between metabolism and flow. Effects on ICP usually not clinically significant.
The central sympatholytic effects also lead to other benefits. Anti-shivering, less stress response.
Yes, anti-shivering action, potential for mild hypothermia, and reduced neuroendocrine stress response to surgery. All beneficial.
What's really fascinating is its use for postoperative agitation and delirium in kids and adults.
Increasingly used for that, yes. A common and distressing complication it seems to help prevent or treat.
Neuroprotective effect is proposed, but needs more proof.
Proposed, yes. But benefits in head injury still need clarification. It can also reduce withdrawal symptoms from sedatives, opioids, alcohol. Valuable there, too.
And it spares the need for other analgesics and anesthetics.
Well-documented analgesic and anesthetic sparing effects. Can even enhance nitrous oxide's pain relief. Great adjunct for multimodal pain control.
Let's discuss cardiovascular effects. Main ones are hypotension and bradycardia.
Particularly with higher doses or rapid administration, yes. Low blood pressure, slow heart rate.
Why does that happen?
Result from central alpha-2 stimulation, decreasing sympathetic outflow, also systemic vasodilation.
Transient hypertension can happen occasionally with rapid loading.
Occasionally, yes, due to peripheral vasoconstriction from high initial concentrations. But dose-dependent hypotension is more common overall during anesthesia.
No direct negative effect on heart muscle itself. Can reduce oxygen demand.
Correct. No direct effect on contractility. Can reduce myocardial oxygen demand, which is an anti-anginal benefit.
Yeah.
Caution needed when co-administering with glycopyrrolate in kids transient severe hypertension reported.
For that unique respiratory advantage, breathing is maintained.
Respirations are remarkably well maintained. Brain's response to CO2 is normal.
Airway patency and reflexes stay mostly intact.
Present or only slightly diminished. This makes it incredibly useful for procedures outside the OR or in difficult airway situations where maintaining spontaneous breathing is critical.
It might even help decrease airway reactivity in COPD or asthma patients.
Shown benefits there, yes. Even blocked histamine-induced bronchoconstriction in dogs. Strong evidence suggests a valuable role in patients with reactive airways.
Here's where it gets really interesting. That big SPICE-3 trial It challenged some assumptions.
Yes, the largest study on dexmedetomidine sedation in the critically ill provided significant insights.
Primary finding. Early sedation with Dex didn't reduce mortality.
Correct. But it did confirm some things. It might not be enough as a sole agent for light sedation in everyone. And there were more adverse events compared to other sedatives in that trial.
And presumed benefits like less delirium or shorter ICU stay weren't seen in SPICE-3.
Interestingly, no. Those benefits were not confirmed in that large trial.
Suggesting guidelines might need updating. Its role as first choice for all ventilated patients is being reconsidered.
Exactly. The data suggests current guidelines may need updating, and its place as a universal first choice needs rethinking based on this robust evidence.
Other effects. Mild diuretic. Renal gut protection.
Mild diuretic effect noted. Renal protective, gastroprotective, anti-inflammatory benefits also suggested.
Widely used now in many procedures, adults and kids. Thought to decrease emergence delirium in kids?
Yes, widely used. Believed to decrease emergence delirium post-op in kids, improving recovery. Its best clinical niche is still evolving, really.
Finally, let's address a very serious and evolving concern. Anesthetic neurotoxicity, particularly in children.
Yes, a crucial topic. Millions of infants and young children receive general anesthesia and sedatives every year. Over the last couple of decades, data from animal studies and some observational human studies raised serious concerns. Could these drugs cause neurotoxic changes in the developing brain, leading to adverse neurodevelopmental outcomes later?
This led to the FDA and IRRs forming that Smart Tots partnership back in 2009.
Right. Strategies for mitigating anesthesia-related neurotoxicity in tots, a major initiative to investigate this.
What's been consistently confirmed in lab animals is concerning drugs affecting GABA or glutamate pathways.
Commonly used anesthetics and sedatives that either increase inhibitory GABA activity like Propofol, Etomidate, the fluoranes, or block excitatory glutamate receptors like ketamine have shown profound neurotoxic effects in developing animal brains.
Factors like age at exposure and dose matter.
Yes, and the histological changes seen are alarming. Widespread apoptosis, cell death, fewer synapses, altered neuron shape, impaired new neuron growth in the hippocampus.
This raises the urgent question, what about human children? What's being done?
In 2014, Smart Tots concluded the animal data was convincing enough to warrant large-scale clinical studies in humans. They issued a statement recommending that, where feasible, surgeries under anesthesia be avoided in kids under 3 unless urgent.
Emphasizing the need to find out if these drugs cause damage in human infants, calling for randomized trials.
Exactly. Urgently needed. The General Anesthesia Study, or GAS trial, was the first prospective trial looking at this in humans. Secondary outcome data on over 500 subjects came out.
And what did that initial data show?
It indicated no statistically significant difference in cognitive development at 2 years old for kids having general versus regional anesthesia for procedures lasting less than 1 hour.
That's somewhat reassuring, but it's just one study, limited scope.
Exactly. Reassuring initial data, but for shorter anesthetics. Research is ongoing.
So what does this mean right now for parents and caregivers?
Smart Tots established an international working group to generate more data to design better, larger clinical trials. In the meantime, the recommendation is that parents and caregivers should be made aware of the potential risks, even though they remain unproven in humans.
Further studies are needed to clarify if injury occurs in humans.
Definitely. So surgeons, anesthesiologists, and parents need to have careful discussions weighing the urgency of surgery, especially for kids under 3, against these potential, though still unproven, risks. It's about informed decision-making. Hashtag tag outro.
Well, that truly was an extensive deep dive into the fascinating, complex world of intravenous induction agents. We've journeyed from that historical context of sodium pentothal through the intricacies of Propofol, our current workhorse,
A gold standard, yeah.
to the stability of Etomidate, the unique state of ketamine, the versatility of Benzodiazepines, and that gentle sedation from Dexmedetomidine. You now understand not just what these drugs are, but hopefully have a much deeper grasp of how they work, their impacts, benefits, limitations, and the critical thinking behind their use. Really aiming for that professional level understanding.
Absolutely. And what's truly fascinating, I think, is how having such a diverse toolkit of unique IV drugs allows clinicians to really tailor the anesthesia induction. We can fit the approach to the specific needs of each patient, the type of surgery, their health status, their susceptibility to side effects.
That ability to choose precisely is key to modern safety.
It's precisely why modern anesthesia can achieve such remarkably safe techniques and excellent outcomes, even as we see increasingly complex patients.
So what does this all mean for you now equipped with this level of insight? You're now profoundly equipped, hopefully, with the knowledge to understand that intricate dance of pharmacology happening the moment you or a loved one receives anesthesia. It's really a testament to medical advancement, balancing powerful effects with incredible precision and safety.
It really is. Which leads to an important question for you to maybe ponder. As medical science keeps pushing boundaries, how might the next generation of intravenous anesthetics further refine this art? How might they ensure even greater safety, more personalization, maybe even eliminate some of the challenges we've talked about today?
A fascinating thought to end on. Thank you for joining us on this deep dive. Until next time, keep exploring, keep questioning, and keep learning.